So again, we continue with another edition of the Osteopathic Lyceum podcast. I thank you for tuning in and engaging. Hopefully you're learning something here, and I am definitely trying to figure out ways to begin to include other people in these discussions. But for now, I think there's quite a bit of value that I can bring to the table by discussing some basic topics and looking at them through available information. So in this case, as I kind of stumble through that intro, what I want to look at is direct barrier methods. Now, the way that we're going to do this is we're going to utilize the glossary of osteopathic terminology, the edition from 2017. I do not believe there is a new edition as of this point. So the 2017 edition we'll have to do. Now, the 2017 edition is not terribly different. And it's the third edition, I believe. It's not terribly different than the previous one. So for those of you who are listening, you won't be able to see this, but for those who have the visual medium, you'll actually be able to see that I'm pulling this directly from that source material. For those of you listening, hopefully I do a good job describing what's there. All right, so I'm going to go ahead and pull this up. So what you can see on the screen at the moment, and as I adjust this, make the video box for myself a little bit bigger, so on the fly as I talk over this, so that for those listening, there's not much dead air. Okay, so we have the glossary of osteopathic terminology, third edition. The executive editor apparently is Rebecca. I'm pretty sure I'm going to say this last name incorrectly. It's Giusti, so it could be Giusti or Giusti. I don't know. Anyways, just want you to be able to see and be aware that we're working from that 2017 glossary of osteopathic terminology, which is the third edition. Okay, so I'm going to advance to page 36. So on page 36 is where we're really going to kind of get into the direct methodology. So just so that people are able to see this, as you go through, you're going to, because it's a glossary, you're going to have things organized under letters. If you see something like balanced ligamentous tension earlier on, then what it's going to do is see osteopathic methods, balanced ligamentous tension. It's going to direct you to the O section. So all the stuff that we're going to be able to grab that has some meaning is going to be from this O section. So what we do as I scroll down, first thing we want to do is just very, very generally, we'll look at a breakdown of some of the initial terms before we really get into what I want to touch on, which is direct barrier methods. So you have the definition of osteopathic manipulative treatment, the therapeutic application or manually guided forces by an osteopathic physician, US usage, to improve physiologic function and or support homeostasis that has been altered by somatic dysfunction. Okay, so that's your general overarching definition of OMT. Now, you will also have OMM, and then there's, I believe, osteopathic manual therapeutics. So that's all there, but we don't have to worry about that. We've got a reasonable grounding. So therapeutic application of manually guided forces by an osteopathic physician. So outside of America, it would be, you could simply adjust this to the therapeutic application of manually guided forces by an osteopathic practitioner, right? So the hands-on application of treatment methodologies. And the thing that would likely stick out that would make an osteopathic method different than any other is essentially that it would be called osteopathic. So if you assay other hands-on professions, be it physiotherapy, chiropractic, massage, the actual holds and ways in which patient bodies are moved are very, very similar. The thing that would be different would be the underlying thought, or at least that's the claim. And the easiest way to see that with respect to osteopathy is actually the barrier concept. Now, the barrier concept is going to very, very broadly have subdivided components. But if you don't worry so much about the subdivided components, such as the anatomical barrier, the physiological barrier, the restrictive barrier, and the elastic barrier, if you don't worry about those terms, then what you can make the claim is that the barrier concept helps the practitioner avoid a pain response in the patient. Because once you figure out where the barriers are through motion testing, then what you're able to do is make a choice as to whether or not you should go direct or indirect, and that's guided by the pain response. So if you're going to go direct, what that means in a clinical sense is that you've identify the restrictive barrier, and you can engage that with the patient, whether active or passive, without the patient showing a pain response. So very broadly, what I tend to say is, as a heuristic for the direct or for the barrier concept, is don't make them say ouch. If they do say ouch, go indirect, and that means make the soft tissue soft. And now we're not talking about that specifically here, but I'll put that out so that it's just kind of in the general milieu, in the ether, so that it's working through those of you who are engaging with this, working through your head cognitively so that it's there. But there's a lot of other places in which I put those concepts out, and maybe you've seen those, maybe you haven't, maybe you will see those, maybe you won't. One way or the other, I'll repeat my heuristics often. But with respect to the direct barrier, essentially what has happened in assessment and treatment activities is the practitioners identified a restriction and also identified that they can engage it without a pain response for the patient. Okay, so it's that particular concept that tends to separate osteopathy from other hands-on professions, because in using the barrier concept, in avoiding pain responses for the patient, that's a unique feature where other professions broadly, not practitioners in other professions, but the professions don't mind the pain response. So some of you who have experience with other hands-on professions, you'll often tell a patient to relax. You'll often tell a patient to breathe through it. You'll often tell a patient that they're going to be sore the next day after treatment. Osteopathic practitioners utilize the barrier concept to generally avoid that. Okay, so what we're going to do is move from here into first we'll go to the definition of direct treatment, and then we'll go through in this glossary to show direct methods and essentially show you that they're going to follow quite well or align quite well with the definition of direct treatment, which would suggest that the definition of direct treatment is likely all you really need if you use a heuristic approach in order to appropriately generate all of the methods that would be contained within these various systems. So essentially what I'm trying to say is all these methods are guided by the exact same thing, so you don't need to remember the details of HVLA necessarily. HVLA is a tricky one because there's a lot of places in which practitioners are allowed to do it and places where practitioners are not allowed to do it. I live in Ontario. In Canada, I'm not allowed to do it. It is illegal for me to do anything that purposely cracks a joint, right? I cannot thrust. It is against the law. Whereas in other places, so I believe in the UK, generally speaking, osteopathic practitioners are allowed to. I believe in Australia, the same is true. I don't know about most European countries, the specific details, but some probably allow it and some probably don't. But that's where HVLA is a little tricky. So if we kind of come back to the point that direct methods, aside really from HVLA, so something like myofascial release, something like something like muscle energy. Muscle energy is essentially a direct patient active treatment. So basically you go direct and you make the patient get active. Whereas myofascial release, at least in its direct form, you go direct into bind, primarily with soft tissues, possibly with a larger movement, and then you just wait, so the patient's passive. So the real difference between them is patient active versus patient passive. That's the primary difference between those two. And we'll touch on that in a couple of moments when I actually start reading this properly and show you why I'm saying these things. Where did it go? Where did it go? So direct method. Right, so the definition of direct method: an osteopathic treatment in which the restrictive barrier is engaged and a final activating force is applied to correct somatic dysfunction. So the general overarching thing for direct treatment is you engage the restrictive barrier. So where there is restriction identified with motion testing, that's the way that the practitioner takes the patient or directs the patient to go. Then something will be added. Now the something could be passive or active. If it's active, you can still use all of the passive stuff first, then make the patient active. And you'll see this in the definition of muscle energy. What essentially is going to happen as far as the passive stuff, you can consider talking about it in the cardinal planes. So you can add some flexion, you can add some extension of a joint, you can add some side bending, you can add some rotation of a joint, or you can move in the coronal and transverse planes, depending on how you want to term that. Or you could say something along the line of compression, distraction, torsion, and shear. And what you're going to do is you're purposely going to go through all of those in an orderly fashion, depending on what you're treating, because some things you can generate all those movements, some things you can't, depending on your hold, depending on the particular piece of anatomy. But you're going to orderly go through those things to identify which one or multiple ones, pieces of that set of steps in compression, distraction, torsion, and shear will generate engagement of the restrictive barrier. Once you've engaged the restrictive barrier in all of the ways that seem useful, you can either stay passive with the patient or have the patient become active. Okay, so that's the final activating force. So all direct treatment is the same in that you're going to get a little bit of tissue tension in one or more planes or through one or more movements, and then something else is going to come into play. Sometimes it's just waiting, sometimes it's having the patient take a deep breath, sometimes it's the patient actively contracting something, be it the particular thing that you're using or the particular piece of anatomy that you're treating, or something distant that will generate some relational motion. Okay, so where's one here? Facilitated functional method is indirect, Galbraith hepatic pump. HVLA would be considered direct. So this is the one that's a little bit more dicey to talk about with the profession at large on account of the fact that not all jurisdictions will allow this. So I will I'll touch on it lightly, but just understand that this particular methodologies, or this particular direct methodology, is not allowed everywhere. So not everybody can do it. Not everybody's going to learn it within the profession of osteopathy. And also it's the one that has the most danger, because if there is some portion of the anatomy that you're treating that has a disruption to it that the patient doesn't know and you don't know and you haven't screened properly or you're not uncertain enough, if you move fast in the thrust, there's more opportunities for things to break, rip, or tear. So we just look at the definition of the HVLA, also called thrust treatment method, an osteopathic method in which the restrictive barrier is engaged. So that's how you know that it's direct in one or more planes, as I already noted, of motion, and then a rapid therapeutic force of brief duration traveling a short distance is applied within the anatomic range of motion. So definitionally, this sounds really nice. You're going to have a hard time ensuring that the force is perfect, that it's in the right direction, that you're actually staying within the anatomic range of motion. It is inherently a dangerous methodology. That's one of the reasons in varying jurisdictions it would be considered a protected act. So in Ontario, it's a protected act. If you do not have an accreditation or a certification or a license that allows you to access that protected act, you can't do it. Osteopathic practitioners in Ontario, in Canada, don't have that. They're not allowed to do it. So now we just move a little bit further to find another one. There's a lot of indirect techniques. There's more named indirect barrier methods than there are direct barrier methods, generally speaking, especially when you look through the glossary. Within the glossary, you're going to see things like Jones technique, ligamentous articular strain, strain counter strain, or it might just say counter strain. Jones technique and counter strain are the same thing, right? You're going to see functional technique. You're going to see facilitated positional release, whereas with respect to direct methodologies, you're looking at muscle energy, HVLA, and myofascial release, but only one subcomponent of myofascial release. There may be some others that I'm not thinking of offhand, but as I breeze through this, I'll let you know. So muscle energy is a direct treatment method which the patient's muscles are employed upon request from a precisely controlled position in a specific direction and against a distinctly executed physician counterforce. This was first described by Fred Mitchell Sr., D.O. So muscle energy doesn't necessarily mean that the patient is contracting the particular muscle that you're trying to treat. That is not always the case. Sometimes what you're going to do is use the oculocephalogyric reflex. So you're going to have the patient look in varying directions, especially when you're working within the suboccipital region, because your hope is that in whatever position that you have the patient, whether they're seated, supine, lateral, what have you, or prone, that if you have the patient move their eyes, the reflex activity is going to engage the suboccipital muscles for the patient to stay level. Now, I will suggest that if the patient is not upright and the head is not tilted, that's probably not going to do a ton, because the patient is not necessarily in a position where they have to maintain level with the horizon. So if they're in lateral, if they're in supine, if they're in prone, it's probably not going to act exactly the way you want it to, but it is possibly clinically relevant as long as you identify that you have a change as a result of using it. So it's essentially one of those things where if you have a patient anywhere other than seated, it's probably an absolute last ditch resort in the suboccipital region to use the OCG. That said, you can also use cross-extensor reflex. That's a little tricky. You can use reciprocal inhibition, so you can contract the opposite side to get the muscle that you want to treat to relax. Right? You could make the argument that that's a little bit more of an indirect method, but it's realistically, it's a neurological phenomenon, so it's probably still well applied. You can have the patient take a deep breath, which is respiratory assistance, because then what happens is as the patient is laying or sitting in relation to an altered position, so the practitioner has positioned the patient to some degree of engagement with restrictive barriers, so you call it correct or position to correction, and you have the patient take a deep breath, then as they breathe, everything moves. So you have the part that you're trying to treat still, and then the entire body is going to move in some way because the patient takes a deep breath. So essentially what you're going to have is, if we suggest that it's the arm, you're going to have a still arm and a moving torso when they take a deep breath. Sometimes you don't have to get the patient to take a deep breath if you have them in the right position. You can just wait. Some people would say that what that would be is more myofascial release, but you could make the argument that you're using respiratory assistance, you're just going slower. So you could call that muscle energy just slow, right? But those are your activating forces broadly within muscle energy. The OCG, PIR, so contraction of the muscle that you're working on, reciprocal inhibition, contraction of the opposing muscle. Then you have cross-extensor reflex, so on. It's respiratory assistance. Probably already said the oculocephalogyric reflex, right? So you've got all those. There's probably some I'm missing because it's not directly here, but it's available in muscle energy things that you're going to look at. So the next method we want to look at, again, so just to touch back on this, the direct barrier is engaged, and then there's some patient active method, which is why what I would say is if you just engage barrier and make the patient active, you don't have to call that muscle energy. If you do call it muscle energy, you're going to try to remember, should I use OCG? Should I use reciprocal inhibition? Should I use cross-extensor reflex? Should I use respiratory assistance? What should I use? If you engage the direct barrier and you think of relational motion, so one thing stays still and one thing moves in relation to it, you can have a still arm and a moving torso. You can have a still torso and a moving arm. You can have a still head or a still head and neck and a moving torso. A still torso, a moving head and neck, right? You can do this over and over again, which is why I prefer a heuristic-based approach. So if I'm thinking about treatment, I'm going to think about whether the patient needs to be active or passive. I'm going to think about the barrier. So if the patient doesn't say ouch, I can go direct. If the patient says ouch, I can go indirect. If I don't want to make a choice, I go indirect followed by direct. And then I think about the tissue or tissues targeted. So realistically, I'm either thinking about motion broadly speaking, or if I have to work specifically on a soft tissue, that's how I would subdivide it. But if you are working in a heuristic-based approach, you have to remember less details. You can pay more attention to the patient. So again, direct methodologies, you engage a restrictive barrier, and then you add something. And realistically, the only difference is whether the patient's active or not. So instead of remembering muscle energy and myofascial release, just think, is the patient active or passive? And if you continue on that way, then you'll fill in the details and you have access to more details or more possibilities because you're not limited by trying to remember the details of a system. So myofascial release, or MFR, a treatment method first described by Andrew Taylor Still, MD-DO, and his early students, which utilizes continual palpatory feedback to alleviate restriction of the somatic dysfunction, its related fascia and musculature. See also direct myofascial release and direct myofascial release. So direct myofascial release, the dysfunctional myofascial tissues are loaded and restrictive barriers engaged with a constant force. So essentially, this is really what I'm talking about, the differentiation between patient active and patient passive. Engage the restrictive barrier, the patient either becomes active on purpose as guided by the practitioner, or they stay inactive, right? That's really all it is. So this helps to support my position that direct treatment is the same, in that all of it engages the direct or the restrictive barrier, and then the difference is the patient is active or inactive, or active or passive, such that you don't need to remember all the details. What you can really do is just think active or passive. Now, useful question, or a useful thing to differentiate between, is how do you know if the patient should be active or passive? What I would say is just choose one first, the one that you prefer first, and then when that didn't work, do the other one. So my preference as a practitioner is to go patient passive first, right? Because it's less intrusive, it requires less effort from the patient, it generates less strain. I should say, I was going to say force, but really it's less strain. And it's easier. It's just overall easier. You hold on to something, you put something into bind or into ease, and you wait. Right, so it's just generally a little bit easier, requires a little bit less thought. If it didn't work, then I will often have a patient become active, but you have to understand that the patient's activity, even if you tell them exactly how hard they should contract, you can't control that as the practitioner, so they may contract more than is useful or less than is useful. It's just more variables to deal with. So I prefer to go passive, and if it didn't work, then I go active. If you like, as a practitioner, you can go active first, and if that didn't work, you can go passive. But just really choose one, and whichever, if it works, you're done. If it doesn't work, do the other one. And I'll just take a look here really quickly. Spencer technique. Spencer technique realistically is articulatory, right? So you wouldn't necessarily say that it's really a good example of direct treatment, because it's a series of 8 movements, right? That's really all it is. V-spread ventral technique, that's real. Nope. Let me just go back up, because I think I missed articulatory technique specifically. Articulatory, yeah. So articulatory treatment, historic term, see osteopathic manipulative treatment, articulatory. And then you look at the thing directly below it, which is articulatory. A direct treatment method employing a low velocity, moderate high amplitude force applied to a dysfunctional joint. The osteopathic practitioner can choose to employ repetitive springing motion or a single movement of the joint through the restrictive barrier. So this again looks at the difference between active versus passive. So you're engaging the direct barrier, and you can either thrust, which I would say don't do in most cases, because there's more danger, and also depending on the jurisdiction, you're not allowed to do it. But it's repetitive motion. So you can call it springing, or you can call it rhythmic. You can call it repetitive. You can call it articulatory. So that articulatory thing is kind of on off. But you're going into restriction, and the patient is passive. So you have another essentially element here, or variable. So you can go patient passive while continuously moving, or patient passive while holding. If you're continuously moving, you call it articulatory. If you're holding, you call it myofascial release, or direct myofascial release. If you're having the patient be active, you can call it muscle energy. Or you can just say patient active continuous motion, patient passive continuous motion, patient passive holding, patient passive, patient active, right? They point to the same stuff. If you're thinking about muscle energy, or if you're thinking about articulatory technique, if you're thinking about myofascial release, there may be more details to remember than are clinically useful, which drives cognitive load up, which is why I suggest a heuristic-based approach. So to kind of wrap all of that up and maybe make it more useful, what we can say, or really say something that we've already said quite a bit, that direct methodologies are the same, aside from, or the real differentiator is patient active or patient passive. The patient passive realm, you can continuously move or you can hold. The patient active realm, you can do everything patient passive, right? So you can add compression, add distraction, add torsion, add shear, whichever ones engage the direct barrier, and then you can have the patient become active. So you can do all the passive stuff, then make the patient active, or you can just do the patient passive stuff, right? So, which is one of the other reasons why I prefer to go patient passive first, because I can do all that passive stuff, and then I can add the active if that all hasn't worked. So the engagement of the direct barrier and holding, or the engagement of the direct barrier with continuous motion has not worked. I can now add in the final piece of patient active or a patient active approach, which generally speaking, I don't have the patient contract any really the region that I'm working on. I have them contract something else. I hold the thing that I'm working on still, and I have the patient move something else. So if I'm treating the neck, I'll turn the neck or the head and the neck, and I'll have the patient turn their shoulders while I hold the head and neck still, or I'll have them push their torso into the table, or I'll have them push a leg, like one leg then the other leg, just depending on what gives me more engagement to the direct barrier or more engagement with restriction without straining the neck itself. So I use a concept that I call relational motion, which is one thing stays still and one thing moves in relation to it. So direct treatments, they all engage the direct barrier without the patient saying ouch. If the patient says ouch, you got to go indirect. So they're the same that way, but they're different in that you have the primary differentiator is passive or active. The passive, you can hold it or you can wiggle it, versus the active, you can be holding and or wiggling, then make the patient get active, right? So you can combine them all through a series, or you can just choose to do one of the three approaches. But instead of remembering the details of each system, if you go to a more macro approach, a more heuristic-based approach, then you're probably going to be in a really good position. So again, direct techniques are very, very similar to one another, which is nice because just the definition of direct treatment lets you access all of those methods. So hopefully that's been helpful to some, and I look forward to engaging with you again.